Thank you, Vonda. I just want to say this is such an extraordinary thing that you've created. I don't know where you went, but this is just fantastic. I was here in August for one of her midlife mastery retreats, and I can just say, like, you've created not just so much information, but so much heart and purpose. We love it. I'm Fulenwider. I'm the co-founder and co-CEO of Alloy Women's Health. Our website is myalloy.com. We have a booth out there. There's our platform. We connect you to doctors, all experts in menopause, and we get you a personalized treatment plan. Dr. Mary Claire Haber needs no introduction. But it's been a crazy couple of weeks, and I just want to say, I hope you know how much good you are doing for women out there. Let's give her a round. Let's get to it. Let's start with some menopause literacy. Can you get your slide up there? Do I do that here?
So, I may have to stand up for this. So I just want to make sure we're on the same page when we start rolling down this, because there is such poor menopause literacy. If you follow me, you might be a little better than most, or follow the menopause, but go ahead and take pictures of this slide. But, why does a woman go through menopause? And by the way, it's not optional. 100% of us will completely lose our ovarian function. And medically, we define menopause as 1 year after her final menstrual period after the age of 45. Well, what happens if it's leap year? Do we have to wait 366 days to define her menopause? What if she's had a hysterectomy or a Mirena IUD, or was born without a uterus? She had a malaria defect. What do those women don't get to be menopausal? Is that not a thing? Menopause represents the end of our ovarian function, and here's why. We're born with all of our ovaries. Eggs, sorry. We're born with ovaries that contain eggs. She's nervous, it's menopause, sorry. So we're born with all of our eggs. And they have to last us until they don't, okay? Men get to make their stuff fresh every day from puberty until they die. It gets a little harder as they get older, but they can still do it. And we continuously lose that egg supply through the process of ovulation. With every ovulation, we lose 10,000 eggs to get one out, okay? And then we also have something called atresia. We're just from the aging process. Now, we can speed it up. If you smoke, you're going to speed it up. If you've had a hysterectomy, you're going to lose blood flow. You're going to speed it up. If you have chemotherapy, radiation, inflammatory, intestinal diseases, all of that, and autoimmune disease will hasten the rate at which we lose eggs. So, see this slide? So we start out, 1 to 2 million at birth. We're down to 10% by about age 30, and down to 3% at 40. So, Vonda and those of you who had babies after 40, kudos. That's hard. Perimenopause, okay, which no one taught me about in residency. Where's all the clinicians in the room? Anybody ever mention perimenopause to you? Yeah. So, it was like briefly, like a word floated out into the abyss and then never talked about again. Perimenopause is the transition when every month in a normal, healthy woman in pre-menopause, we have a feedback cycle that goes from the hypothalamus to the pituitary to the ovary, month after month after month. And it's very reliable and predictable. On day 14, you're going to do this. On day 21, you're going to do that, over and over and over again. And then when you get to perimenopause, the egg threshold is so low that the signals coming from the brain stop working. Our ovaries become resistant. So the brain gets upset. Where's my estrogen? It's constantly sensing for estrogen, and when the levels drop in a normal menstrual cycle, it starts rolling back up with LH and FSH. Okay? Well, now the same levels of LH and FSH don't cause an ovulation, so the brain gets upset. We start having brain fog, mental health changes, and then your ovaries, it pumps out more higher levels of FSH. Turns out we have FSH receptors all over the body. Other things start going haywire, like our livers with our cholesterol. Whose cholesterol went up in perimenopause with no changes in your diet or exercise? Yeah. So then we end up with this very chaotic, for 7 to 10 years, what used to be this normal EKG-like predictable, it becomes the zone of chaos. Our brains hate it, our livers hate it, our bones hate it, our muscles hate it. Our body starts telling us, something's changing. Let's go to the next slide. And then menopause is when you're out of eggs. You're done. The factory is closed. There's no more production of estradiol coming from that ovary, or testosterone, or progesterone. So this is a fabulous paper. These are the G protein-coupled estrogen receptors throughout the body. I did not know this. No one taught me this in medical school, or a 4-year curriculum in a fabulous OB-GYN residency. Super proud of what I learned. I can deliver a baby blindfolded upside down in the middle of the night with no sleep, running on caffeine, okay? No one taught me this, that we have estrogen receptors all over our bodies, in our brains, in our lungs, in our heart, in our endothelium, in our kidneys. And then the orange parts over here, or coral, are the diseases that are accelerated and affected not just from the aging process, but from menopause. Take a picture of this slide. Take this to your doctor. So, like Dr. Wright was saying today, the musculoskeletal syndrome of menopause, you know how hard she had to fight to get that paper published? You know how many journals turned her down? The orthopedic journals turned her down. It was a menopause journal that got it published, and now starting to be recognized. We're trying to get the metabolic syndrome of menopause published. Pray for us. Let's get a little harder.
Yeah, I mean, you could just keep going. And by the way, just so the clock's not working, so we're going to be up here until you drag us down.
The shepherd's crook.
Dr. Mary Claire, why is it so hard to get menopause care and treatment?
So, because we weren't trained. You know, we weren't taught, we weren't trained, we were taught that menopause was a few bothersome hot flashes, and really if she's complaining that much, she's just really whiny. You know, I was taught in my residency, this is just what women go through at this age. When I would have a patient with multiple day complaints in her 40s, my upper level residents would teach me, this is a whiny woman, WW. In other parts of the country, it was called whiny gynae. In Miami, it was TBD, total body dolor. And in New York, it was Madame Dolores. So this is taught that women just go through this at this age. And you know what? They're right. But nobody questioned why. It was this collective mindset of women just like to complain when they're in their 40s. And even now, today, when you read some of who are considered the most preeminent researchers in menopause, which I have a huge problem with, you will see sidebars. Women are going through a lot at this age. I was handling my shit, okay? I had it covered. My stress levels are the same. Yes, I have aging parents. Yes, my teenagers are driving me crazy. I had it handled. This is what my patients were telling me. Nothing in my stress level has changed. Something inside of me has changed. So why is it hard? Because we're not training, we're not teaching, we're not prioritizing women's health after reproduction. All of the research, the vast majority of the research and funding for women's health goes to pregnancy, very important. We need healthy pregnancies. Breast and ovarian cancer are important things. But when we look at the cardiovascular data, musculoskeletal data, women are small men. They're not deaggregating most of the data for females. And we are suffering the consequences. A woman can expect to live 25% of her life in poorer health than her male counterparts, and it's fucking ridiculous. And it's not because we're living longer. It's because we aren't studying. We're not separating us out. How do we react? And then let's look at the ethnic data. I mean, okay, let's get the females out, but then we have different genetic heritage. You know, it's like we're not looking at specifically how women are aging with disease processes, where menopause is a part of that, and then looking at different ethnicities.
We hear the suffering all the time in our support groups at Alloy. Women who have suffered on average 3 years before they find us, many of them went to 2 or 3 doctors, and they are mentally suffering, their relationships are suffering, some of them have been fired from their jobs. This is really
worse.
Yeah, all the relationships crushed. So this is great work that you're doing, getting the word out. What is the solution?
Education, funding, probably legislation. We need to, I think every clinician who touches a female should have mandatory training and education in menopause.
And for the vast majority of women who are in menopause, what are the medical options for her?
So So I like to look at it as a toolkit, right? And so when we look at, if we just silo forever, the only thing that was studied was vasomotor symptoms, because you can't blame that on much else, okay? A woman having hot flashes, it's either tuberculosis or menopause, after the age of 45. We can rule out TB pretty quickly. So, but no one was looking at the accelerated rates of cardiovascular disease, musculoskeletal syndrome, autoimmune disease, all these things that kind of suddenly surge at 40, 45 in females. And so that is where we need the research and the money and the understanding to go. I mean, is not the last third of my life just as important as the rest of my life? Don't I deserve this?
And a lot of the conversation about menopause treatment in the last 20 years has been about the fear of breast cancer, which is real, and breast cancer is a terrible disease.
Right.
But there are other things that are statistically worse for women, like cardiovascular.
Right, the number one thing a woman's going to die of is a heart attack, even with the diagnosis of breast cancer. And if she has breast cancer, and the treatments are siloed again to decrease the recurrence rate, I mean, there's no one's denying that data. Where I think, and other experts in the room will talk about this, where we're failing women is we're not talking about the effects of these medications on other organ systems, and stop complaining, use some coconut oil. You're not dead of breast cancer. It's like the rest of her health is not being considered, and this is just a microcosm of what's happening on a broader scale. We're being siloed into breasts and uteruses and treated as small men in every other way.
Okay, and the number one first-line treatment for this is, if anyone
Menopause
does
hormone
not know,
therapy is estrogen plus or minus progesterone, and likely, as you'll learn more today, testosterone.
and there'll be a lot of talk about all the solutions, but that simple, adding extra hormone into your body, the hormones that your body needs.
Just giving you back what you used to make. It's called hypogonadism. And in men, you would automatically, where I've learned the most is from the urologist who give a shit about women. Kelly Casperson, where are you? I mean, this woman, and her perspective is, we are treating men and women differently. A man has hypogonadism, we automatically jump in and fix him. A woman has hypogonadism, otherwise known as menopause, and we treat her very, very differently. Like these hurdles and silos that we have to run these mazes and gamuts rather than just give her back what she's missing.
Or at least give her the conversation.
Menopause is not a health neutral event. Our bodies are irrevocably changed in multiple organ systems. And why? I don't make this up. I'm not this smart. I don't do this research, right? I don't sit in labs and do these things. I just read other people's papers and talk to you about it on the internet, and that pisses a lot of people off.
And it helps you more the joke that we all know, and I don't even remember who first told the story, is that if a man goes into a doctor's to talk about ED, they're given, here's some options. Oh, and the risks are, by the way, you could die on the table, you could have a heart attack and go blind. And the guy's like, okay, I've assessed my risk factors, I'm gonna take it. But women go in for menopause, also maybe just talking about sexual dysfunction, or any of the other 34 to 134 symptoms, and the doctors say, they don't even give them the conversation, right? We all deserve to hear our risks versus our benefits.
It's natural. Have some wine.
So knowing how medical school works, how long do you think it'll be until the training changes and doctors are able to, because the thing is so many
generations. Well, from research to changes in clinical practice is 17 years on average. We don't have that much time. My daughter's in medical school. A few people came up last night whose kids were in med school. And it's better, but we got a ways to go. This has to be mandated. Part of, we have to go to the alphabet agencies that are designing curriculum and insist. And that takes a whole lot of people getting in a room to all agree on what we can all teach, whatever. But in the meantime, I'll teach you on the internet.
And also the You've traveled the country, you've spoken to hundreds of thousands of women, all different levels of education and access to care. What is the number one question that you get from women? And what advice do you give them?
Why did my doctor tell me X, Y, and Z? You know, I don't want to throw any individual clinician under the bus. We weren't taught. I was a terrible menopause provider, and I will completely acknowledge that. And so most of us in this room who were doing menopause care had to seek training outside of our traditional, you know, even our CMEs. There was nothing in my continuing board examinations. This year we had 6 out of 72 menopause. Of the articles required for OB-GYN board's recertification, we had 6 that even mentioned the word menopause. And the head of that organization and I were at a meeting and I was like applauding her and she rolled her eyes. She's a little bit busy with reproductive rights right now and training programs, but I was like, yay, we had 6. That was more, 6 was more than we've had in 10 years combined. So we're getting, you know, but you guys can't wait for that. It's a generation. So I love the option of and she's not paying me to say this, of these great online providers to fill these gaps.
And what has been your biggest surprise going around the country and hearing? What are women complaining of the most? What are they coming to you and crying about?
Just they lost their resilience, their lives. You know, the symptoms are broad and varied and whatever, but just this sense of loss, the sense of losing themselves, of who they were, you know, and just wanting to get their baseline function back. Really.
We are big proponents of HRT at Allo. We also have non-hormonal options, but we always like to say that, you know, all the HRT in the world and 0 lifestyle changes is not going to give you this healthy.
Right, you're not going to get the health span.
And all of the lifestyle changes in the world without some sort of other intervention can help, but isn't going to like really return your estrogen to your body. What do you, and I know you wrote a book that I love that you don't like the title of anymore called The Galveston Diet, which has been super helpful.
Diet is a bad word.
But what are when you're talking to women about their options, what else are you telling them about their lifestyle changes?
So in my clinic, again, I have a very bougie private menopause clinic that most regular practitioners could not support because I spend an hour and a half with my patients. We got to unpack all the menopause trauma and, you know. But they walk out with a nutrition plan, a body scan, a body composition scan, and their nutrition plan is based on how much muscle do they have, how much visceral fat, where is it, you know. It's very comprehensive. I have an exercise, you know, I don't teach them how to exercise, but I give them goals, you know, kind of based on their muscle mass and where they are. We talk about, you know, stress reduction, you know, what a good solid nutrition base looks like, you know, and it's not rocket science. Avoid processed foods. Eat lots of fruits and vegetables. Make sure you're getting plenty of protein to support your muscle growth. I just read someone write, it wasn't me, but it was like, health span, lifespan is cardio, health span is muscle. I cannot, you know, oh, our sleep person's here. Sleep optimization. If you're not sleeping, nothing works. So we are prioritizing sleep and not with sedatives.
We are out of time, I think. I wish we could take questions, but this was fun. But thank you.
Final words. Menopause is inevitable, but suffering is not. And like Dr. Wright said, you deserve the last third of your life to be the best third of your life.
Amen.